Okay, Karen? Yeah. Oh boy. For some reason.
Oh, they put me. Oh, so yeah. So then maybe I should go to. Maybe I should go to put my name too. Okay. I don't know.
Okay. Sorry, we're having a little bit of difficulty technically today. Yesterday our electricity went off, which means if that happened again during our session, then we would lose you all and you would lose us. So we're trying to co-manage this session with another computer that has a battery backup in case we lose you. So wonderful heat in LA is causing this problem. All right, let us get started. So today is Wednesday, May 14th, and I feel like we should celebrate. It's our 40th session, so we've been having our Adult Psychiatry Knowledge Network sessions for almost 2 years now, due to everyone's really hard work and participation, and we're very proud of it, and hopefully we can continue to get some grant funding so we can actually pay some of the people that are working so hard. Today's session will be about sleep and insomnia and primary care. And again, it's our 40th session. I wish I had candy to pass to the computers to have something sweet, because it's been very sweet for me to be the facilitator of these sessions. Dr. Curly Bonds is our specialist mentor. He's MD and CMO of G.D. Hirsch Mental Health Community Health Services. And we will turn the ball over to Dr. Bonds. The only couple of things I do want to do is housekeeping. For our newer people on the session, Dr. Mahmoud and Mark Lovegren and Tracy Grotto, who are visiting us from Portland. Basically, we go through housekeeping, saying please keeping yourself muted when you're not speaking and you don't have the floor. Type any clinical questions that you might have or pertinent comments into the chat box so we can all see them and capture them in our notes. Make sure that if you're in a common room or a room that has lots of noise coming into it, you keep your door closed. You keep any of your cell phones or beepers on mute so we don't hear all of that, because we will hear everything that goes through your microphone in your computer. We'll all hear it on the other end. Also, if you're calling via the telephone, unfortunately, you cannot use the speaker, can't use the phone in speaker mode because there's a terrible reverberation and echo, so you will have to hold the phone to your ear. You can choose to be seen by clicking on your camera, which when it's green, you're being seen. When it's gray, you're not. And of course, the microphone, it's muted when it's gray, when it's red and has a line through it, and it's unmuted when it's gray. So pretty simple stuff. Most importantly, we have to be in compliance with HIPAA. So when you are talking about a patient case or cases, do not mention any patient identifiers. Medical information, of course, is fine, but no personal information on cases. And last but not least, our disclaimer is Project Echo LA case consultations do not create or otherwise establish a provider-patient relationship between any clinician and any patient whose case is being presented in a Project Echo LA setting. And I think there you have it. Karen, can you pass the ball to Dr. Bond?
Okay, thanks so much, Karen. So I think we have a couple of folks that aren't as familiar to the echo as others. So in order, I'm just going to go down and do sort of a roll call. And if you could just tell us a little bit about who you are, where you work, and in what capacity, like your discipline, and just to introduce yourself to the group. I'll start with Dr. Johnson and her team.
Okay, we picked up the phone, so there wasn't echoing. I'm Dr. Johnson. This is Deanna, Kim, and Matt. These are my interns who work with me here. We're part of Chapter Medical Clinic, and we're just around the corner from Dr. Mahmoud and Dr. Pierce.
Okay, great. And then I see Catherine Steffen is with us again.
Hi, I'm Catherine Steffen, family nurse practitioner at Northeast Valley Health Corporation.
Okay, great. Good to see you again. And then I see Mark Lovegren.
Hi guys, Mark Lovegren from Oregon Health and Science University, and I'm the director of the telehealth program. And we're looking at developing an echo model up here in Oregon in partnership with our local ACO, and I'm going to turn it over to Tracy.
Hi, this is Tracy Grotto, and I'm with Health Share of Oregon, partnering with Mark to get one of these off the ground. Thanks for having us.
Oh, very good to have you all too. OHSU, I have fond memories of a very wet January up that way as a medical student. So next we have Monica and Crystal.
My name is Monica Ellis. I am a behavioral health extern at Hubert Humphrey, which is a Los Angeles County clinic serving adults with HIV and AIDS.
And I'm Krista Clemens, and I work in a group home at the Dream Catcher Foundation, which is a group home for adolescent girls and in-house therapists.
Welcome. Last but not least, Dr. Pierce.
Hi, Sam Pierce, Internal Medicine with Arrows Clinic. I'm here with Dr. Zainab Mahmoud, who is family practice, and she's very interested in learning and finding out about all the goings on with Echo LA.
Okay, great. So as has been our tradition, I want to invite anyone who may have been thinking about or holding on to secretly a case to let us know if you'd like to present that during the ECHO. We don't have any pre-submitted cases today, so we have plenty of time to either present a spontaneous case or to have questions related to the presentation, which today is going to be about insomnia, and it's going to be focused probably more on the different categories of sleep disturbance, a little bit less on treatment. So if there are treatment questions, we can address those just in the limited amount of time that I anticipate that we have. I didn't go into a long didactic about medications. I know that insomnia has been covered before. A part of the presentation will be a little bit about some of the modifications to classifications based on the DSM-5, the Diagnostic and Statistical Manual, which has been out for a year now. I'm fresh back from the American Psychiatric Association meeting and certainly can give you some updates about other topics too. And I see that in the interim, Nicole Gentry has joined us. Nicole, can you please introduce yourself? I don't see a microphone for Nicole, but know that she's a physician assistant who works with us over at our Inglewood site. She's affiliated with the South Bay Family Health Center. So welcome, Nicole. Any follow-up cases or people that you've seen in the past that you got feedback from the ECHO about that you were either able to implement or that you tried different interventions with, and if you can let us know how those are turning out, we'd be happy to hear about those too.
Did you unmute me? Yeah, this is Dr. Johnson. I do have an update that is an example of the expanding of the advice that you were able to provide to us. We've had probably in the last 6 weeks about 3 patients who are pregnant who have prior history of using antidepressant medication and then are very concerned about continuing and have asked their providers here about it. And with the information that you gave us on that one case, we were then able to share that with the other providers who then felt very comfortable and happy discussing those issues with their patients, whereas before they didn't really have any idea of where to go. So I just wanted to let you know that that information, not specifically with that patient, but that information has been useful throughout the clinic and has dispersed itself well. So thank you very much.
Oh, wonderful. Glad to hear it. And I think down the road, Karen is working with the LA Perinatal Task Force because they, in the past, have had some funding to do specific didactics. I know that they've come out to our center and talked about pregnancy and psychotropic medications. They do have a few physicians who are speakers that are either volunteers or they get some type of an honoraria to do this. So that would be great. And
yes, I am working on that.
Great. And it looks like, Dr. Johnson, you have a case as well? Or you have a follow-up? Oh, we can't hear you right now. It looks like you've been muted, Dr. Day. I don't know. Karen,
it was, yeah, sorry. We got it. No, we don't have a separate case, unfortunately, at the moment. We are thinking about the patients that we've been seeing recently, but so far, you know, we're doing pretty well. It was just the update on the patients, the pregnant patients who are seeking additional assistance with medication. So thanks.
Before we move on, any other updates? Questions? Well, why don't we do the didactic? And if we don't get cases, I'll prepare you all that I have gleaned from my own private practice notes of some of the folks that I treat that have issues related to the day's didactic. So if you all don't have questions, I can kind of pinch hit and I would talk a little bit about things. So next is our didactic, and I need to go back to the beginning of it. And just as a disclaimer, this is not one that I created. It's actually another borrowed didactic from a sister ECHO. I believe this one is over at University of New Mexico. They're the original founders of it, and they've graciously agreed to share some of their learning materials so that we don't have to recreate the wheel. I will acknowledge that their ECHO is slightly different in structure and that they do a very much more extended didactic than ours. Today, this actually might work out because we have the luxury of time, but some of the slides go into a little bit more detail than myself as a primary psychiatrist do not necessarily know all the specifics of, but I think for our purposes, we'll be able to fixate on the important points, which are diagnostic as opposed to some of the technical parts of, say, sleep studies. But if anybody has more knowledge about this, certainly feel free. Again, it's a community of learning. So this particular ECHO presentation was created by Daniel Duig, who's a DO out in New Mexico. And then move on to the next slide. Can everybody see the slides? If not, do let us know. And like Dr. Duig, I have no disclosures, no relation to pharma or any sleep drugs. So staying awake. I think when we talk about sleep, one thing we need to be aware of is that one thing to establish is that the people are actually alert. So of course, a part of the mental status is wakefulness. And in some ways, this presentation frames it a little bit differently because it talks about both the excitatory pathways and also the inhibitory pathways, because of course the opposite of sleep is wakefulness. We know that glutamate and aspartate are the excitatory neurotransmitters, and you can see here how they circulate around, especially the midbrain and the forebrain to promote wakefulness. Next is the reticular activating system, which is primarily glutaminergic, and these are signals that are sent throughout the brain to maintain arousal at the cortical level so that there is wakefulness, and you can see all the sensory inputs that happen on this slide as well. So the RAS sends out diffuse signals to stimulate the brain to wake up. This says that you need to be functioning, you need to be doing things. It tends to happen as a function of waking up and starting the day. Both acute and chronic pain are very disruptive to sleep, and this is one of the reasons because this reticular activating system gets woken up. This system is also important in attention deficit disorder. When there are differences in midbrain function, sometimes there can be misfirings there. Next, talking about going to sleep. One of the important neurochemicals in this regard is melatonin. Probably you're all familiar with it. It's something that people can now purchase over the counter, health food stores, even grocery stores. It's secreted by the pineal gland, which is light sensitive, of course, and it's secreted in response to darkness. The melatonin in the body is really something that causes the release of norepinephrine from the postganglionic sympathetic terminals, and then there's a series of different mechanisms that result from that, ultimately resulting in G protein coupled receptors, M1 and M2, which are the receptors for melatonin, being activated. And what melatonin does is it actually turns off the suprachiasmatic nucleus and prevents it from promoting wakefulness. So in a way, melatonin isn't just a sleeping drug in the way that some of the others are that bind to benzodiazepine receptors. It's a drug that really promotes the inhibition of wakefulness, so that, in other words, kind of works in reverse, which is why it's kind of a gentler sleep aid. This next slide shows some of the stages of sleep and sleep architecture. In the pink at the very caps of some of these peaks are REM sleep. As you know, that's the random eye movement sleep, which is when dreams occur. Some people think of them as being Rorschachs that are projected onto physiologic movements, but it's a relatively small part of sleep. And as you can see, there's a very periodic way in which people go in and out of wakefulness over the course of the evening, in and out of different levels of sleep. You can see that there's stage 1, 2, 3, and 4. My understanding is that not everybody will always get to the deepest stages of sleep, but those tend to be viewed as being more restorative, and those are the types of sleep that people think of as really valuable. But in a sleep study, you would get a sense of whether people are going through this more quickly, more slowly, but this is what it looks like if it's in a healthy individual. What you might be interested in knowing, too, is that there are a lot of products out right now, like the wrist watch items where you can actually set it to wake you up at a certain time. And what it's trying to do is to judge when you're going to be in one of the lighter stages of sleep so that it will wake you up from that as opposed to waking you up from stage 4 sleep. So there are some products now that kind of take advantage of this sleep cycle periodicity. This slide just highlights how across the lifespan, the nature of sleep changes a bit. Most of us are aware that older adults, which are at the bottom of this slide, tend to have less satisfying sleep with more episodes of wakefulness. Their cycles are a lot smaller, and their periods of deep sleep are a lot shorter in terms of overall. This is a little bit different than kids, which spend a great deal of time in stage 4 sleep, as you can see, and much less in the lighter stages of sleep, which is why you can put them down and sometimes have a whole party around them and they'll just sleep right through it. Not so true with older adults who tend to spend a lot more time in the lighter stages of sleep. And by the way, with a question, how old is elderly? I would say when you get north of 55, probably more into the 60s. So it's someplace that we're all headed. But feel free to type in other questions if I move too quickly. Now, this slide, I'm not exactly sure what the main point is. Again, these are not mine, but it seems like one of the key points is wake after sleep onset. There's chance that this will increase. You see the second bar that's very light pink or maybe almost white. It tends to be that the wake after sleep onset period, or the likelihood of that happening after people get older up at age 85, it's a fairly large piece of that graph, whereas if you look towards the 5-10-year-olds, it's a very small piece. And also you can look at the changes in stage 1 and 2 sleep, how those increase, whereas the deeper stages of sleep tend to fluctuate. So as I promised, we would talk a little bit about some of the disorders that are related to sleeping. And these are, I think, classified generally speaking as the parasomnias. Oops, went too fast. So there are a few definitions of insomnia. If you look at DSM-4 and 5, it's defined as difficulty in initiating or maintaining sleep. Sometimes you'll hear these referred to as the DIMS, the DIMS being for difficulty maintaining sleep or difficulty initiating sleep. Non-restorative sleep that causes clinically significant distress or impairment in social, occupational, or other function. So it's not just that you don't sleep enough, but there's some impairment. And this is pretty critical, because a lot of folks will come in complaining that they don't sleep enough or they don't sleep much. And they might say that they get 6 hours of sleep. Well, this may be because they're familiar from their younger years of sleeping maybe 8, 10, 12 hours. And now that they have more day-to-day responsibilities, they're only getting 6 hours. But they're still able to do the things that they need to. So they may have an unrealistic sleep expectation. So for me, in taking a sleep history, it's very critical to ask, what time do you turn in? What time do you wake up? To get a sense of total time in bed. And then you want to supplement that with questions about, do you have periodic awakening during the night? Do you wake up earlier than you need to? Or do you have difficulty falling asleep? I think that this may come up earlier, but you classify that as initial, middle, or terminal insomnia based on the stage of sleep that's interrupted. But a key piece is finding out how much time do you have in bed. And of course, an average is between 6 to 8 hours, 6 being the shortest period that most people are able to function well, 8 hours being kind of at the outer limit. But there are those folks who need and must have 10 to 12 hours in order to function well. In the ICSD-2, it's defined as repeated difficulty with sleep initiation, duration consolidation, or quality of sleep that occurs despite an adequate amount of sleep that produces daytime impairment. There are some additional clarifications. 10 to 15% of the general population has chronic insomnia, defined as not getting enough sleep and not being able to be fully functional as a result of it. And the prevalence of insomnia is much higher for patients who are seen in general medical settings, like those that most of you are practicing in, where it's about 25% to 35% of patients that have some transient sleep problems. A lot of times that'll be associated with pain, pre- and post-surgical, for example, anxiety about having a procedure, or even pain afterwards. And 90% of patients with insomnia have comorbid problems, including psychiatric disorders. So insomnia is more of a symptom in a lot of the people that I treat, but sometimes I've discovered the old belief was that if you got the depression better, the insomnia would then improve as well. We now understand and appreciate that that's not always the case. There are those folks who, because of the chronicity of their insomnia, may well get better from the depression, but be left with that. The problem with not sleeping. This slide just kind of shows in a very graphic way what the results are if you don't get enough sleep. If you look at the bottom, it's days of nocturnal sleep restriction. I guess this would be, say, putting someone in a sleep-deprived setting, and you look at the amount of errors ranging from 0 up to 16 and greater. The least amount of time that someone spends in bed, you can see the orange graph or line on the graph, where there are a huge number of errors that happen as a result of sleeping less than 2 hours. In fact, that person's probably prone to be driving into other people, dropping things, deleting files in their computer when they didn't mean to. Whereas if you get 8 hours in bed, the number of errors tends to stay below 2. So it's a strong argument that we really do need to sleep. They looked at something called psychomotor vigilance task. Not clear what the definition of that is, but it's some operational measure in the sleep lab of how someone can function in terms of, I guess, hand-eye coordination. It looks like Dr. Johnson's sharing something with her group. Feel free to chime in if it is worthwhile. But I guess I know that with medical students, for example, you can tell when they're post-scholar residents.
Yeah, we were just interpreting the chart because PVT, 0 days 0 hours in bed after 1 day of sleep restriction, you're making 8 mistakes, which could be crucial if you're driving a car. So, yeah, okay, that was it.
Slow down. Thanks. Yeah, it's a kind of a multimodal, it's a multitasking chart actually. It has both sleep deprivation and the further out you get, even the folks who are getting 8 hours, if they get less than their primary or their baseline amount, it looks like they're making more mistakes too, even though it's far fewer than the folks who don't get much at all. So this slide summarizes some of the causes of insomnia, always due to something. Primary insomnia means I haven't figured out the cause yet. So this is a bias of, according to this investigator, the cause may be neurohormonal, behavioral, chemical, environmental, or psychiatric. So I guess that some of the sustaining reasons are what we really want to explore. Our job is to help the patient find out which one it is and then to make recommendations. So there are a variety of ways to do that. Of course, history is one. Having people keep a sleep journal, which I often do, can be a little bit problematic because if they're waking up at night to write down things, that tends to impair sleep. So I actually advise them to do it the following day, like not to do it during the night. This, again, are the 3 types of insomnia as I predicted or foreshadowed. There's early, middle, and terminal. Terminal does not mean dead. It just means that it happens very early in the morning. And there's some classic associations between the different types of insomnia and what the likely underlying cause is. I was always taught to believe that terminal insomnia, which is what we see mostly in major depression, is because people just have a circadian rhythm disturbance. And antidepressants will often help to fix this. In fact, one of the complaints that I've had from folks who are successfully treated with antidepressants is that I'm sleepy in the morning and I can't get up. And that might be a function of the fact that they've had such chronic depression that when you restore their mood, then they need to sleep longer and they need to allow more sleep time. So it's an important thing to think about. Middle insomnia being waking up throughout the night can often be related to pain, medication withdrawal, repeated stimulus effect, or nightmares. I would say that another possibility is obstructive sleep apnea, which I think is covered in some of the later slides. Early on, difficulty falling asleep. There can be anxiety associated with this, and as well, some of the things that people ingest. Caffeine, one look at all causes and sources of it. For example, chocolate, sodas, coffee, of course. Most people need to cut those things off probably midday to avoid them impairing sleep. And likely stress, and then just poor sleep hygiene. One of the things that I've learned about a lot is that many people, before they turn in, will begin to go through their phone or go through their email, and it's just not a good idea to do too many activating things right before sleep. And certainly exercise too close to sleep onset is another problem for a lot of people. Sleep disordered breathing. This lists a lot of different causes on the left, along with some visuals, which those of you who are doing physical exams can investigate. Different palates are more likely to be associated with different types of obstructive sleep disorders. And these are best diagnosed by polysomnography, generally a covered benefit, and the results will come back showing if the person has several episodes of wakefulness throughout the night. And they can also be given the Epworth Sleepiness Scale, and a score above 9 suggests that there might be some type of breathing difficulty related to sleeping. Other classic signs, people that have a lot of headaches during the day, people who have high blood pressure, diabetes, or prediabetes are often at risk too. So we have a question: how long does one have to stay awake for it to qualify as middle insomnia? That's a great question. I don't think it has to be a long time. I think it's just mainly that they're aware that they're awake. It can be a matter of minutes. Sometimes it's just a few seconds, like they wake up for 30-second intervals and go back to sleep. But they're just aware during the course of the night that they wake up and they have usually are able to get back to sleep, but sometimes they can be awake for an hour or two. So I think just a matter of minutes to hours is how it's rated. This is a EEG combined with EMG that just shows obstructive sleep apnea. These arrows point out the places where the person is awake. Generally, they're alert enough. And one explanation for this is that it's the brain's way of saying we're not getting enough oxygen. We're going to send this activating signal down to the muscles to move and have people wake up. And a lot of times that's associated with snoring. So there's a measure of both ribcage motion and abdominal motion because the person will have sometimes a very violent waking up with a snort. So here's a question When elderly individuals complain about middle insomnia, should we educate them about normal sleep patterns of the elderly? At what point should we be concerned? That's a good point. I think a little bit out of my scope because I don't do a great deal of geriatrics, but my sense is if they're complaining about it and they also can demonstrate some difficulty in functioning, especially daytime falling asleep, difficulty with attention, and if they have any good nights, to ask, do you ever have times when it's okay? Because then that could give you a sense of whether or not this is a periodic problem or if it's a chronic problem. But if I have folks who are complaining, then I try to get them in to get a sleep study, honestly. Sleep apnea kills people. Pretty dramatic title, but it's actually true. If you look at the people with obstructive sleep apnea in yellow, and you look at the people without sleep apnea in pink, you can see that the mortality in terms of deaths is quite high from those folks who do have obstructive sleep apnea in the early morning hours between 11 o'clock at night and 6 in the morning. And is there a higher incidence of sleep apnea in older adults and the elderly? My sense is that say yes. There are different types of apnea, though I think in kids they can have more of a neurologic apnea that has to do with just brain malfunction or developmental disabilities. But a lot of times obstructive sleep apnea has to do with anatomy. It also has to do with being overweight, something about neck birth. I can't recall exactly, but I think in men, if their shirt size is above a 16.5, 17, then they're at greater risk. So it tends to happen a lot as people accumulate fat around the neck. Sleep apnea kills people, again, just showing that over the course of years, the sleep apnea rates increase. This may address that question, that yes, there is a much higher incidence in older adults. Cumulative frequency of sleep apnea. So this doesn't show age, but I guess over years it shows that even, I guess, in terms of people being followed with sleep apnea, the risk of death increases over time. Next is narcolepsy, which is sometimes I think, fallback diagnosis for a lot of people that have behaviors that they can't explain, but not exceptionally rare. These are some of the symptoms on the left of narcolepsy. If you've ever seen the film My Own Private Idaho, if not, it's one of Keanu Reeves' early career films. Interesting and entertaining, but it also has a great portrait of narcolepsy. Sleep attacks, which are the sudden onset of irresistible desire or need to sleep. Cataplexy, which is the total loss of muscle tone. They're like drop attacks. Then sleep paralysis, total paralysis with onset of sleep at the same time, or upon awakening. It's a terrifying experience. And then hypnagogic hallucinations and poor sleep at night. These are the 5 characteristics. The hypnagogic hallucinations, just as a reminder of some of the vocabulary, hypnagogic means at the time of onset of sleep, whereas hypnopompic means time of onset of wakefulness. So these are hallucinations that we don't consider to be in the psychotic spectrum at all, and they can be considered normal, and we don't necessarily think of them as being psychiatric diagnostic of some psychiatric condition. But if you look at patients who have narcolepsy, the vast majority, overwhelming 100%, will have sleep attacks where they just fall into sleep without planning to. This can happen while someone's driving, standing in line at the grocery store, sitting quietly watching TV. But then some of the other things are less common, like the hypnagogic hallucinations. So just gives you a sense that these symptoms are pretty common throughout the world of narcolepsy. There is a test that can detect narcolepsy, the multiple sleep latency test. It's something that I generally would expect to get back from a sleep lab. The patient naps 3 to 5 times throughout a day in the sleep lab, and it tests the latency of sleep onset. There's a measure that we think of as the time that your head hits the pillow to the time that you actually fall asleep. And if that's prolonged, then it can be suggestive. Restless leg syndrome is another. Oh, just as an aside, there is now also a test, hypocreatine, for narcolepsy that requires an LP, which some sleep labs do, but it's a send out, it's fairly expensive, hasn't fallen into the mainstream because people just don't like doing LPs, but at least up at Stanford, it's considered, according to Dr. Minot, the most classic tool to diagnose sleep or obstructive sleep apnea at this point, or sorry, narcolepsy. So this is talking about restless leg syndrome, which I think because of late night television commercials, a lot more people are aware of now than they were, say, 10 years ago. Some of the components are listed in the very tiny font. Akathisia, the need to move or an extremity or the back that is relieved only by moving the muscles. So a sense of I need to kind of motor myself around, similar to what you see with folks who are taking antipsychotic medications. It can be defined as an itch or a pain, treated with dopamine agonists, and there are case reports of compulsive behaviors, for example, drugs like gambling that resolve with discontinuation of the drug. Periodic limb movements and sleep, these can be found, I guess, if you were to do an EMG during a sleep study. But it can sometimes be one of the causes, and the video for these are pretty dramatic. Circadian rhythm disturbances, these can result from shift work. If anybody's ever known nurses who have to go from one shift to the next, people that drive long hauls, jet lag for people that do a lot of international travel, sometimes even east to west travel can be problematic. Probably west to east is more difficult in terms of triggering psychiatric difficulties. Advanced sleep phase disorder and delayed sleep phase disorder, just in that you're going to bed way too early or you're having trouble waking up too early. The parasomnias, these are, I think, frequently diagnosed in psychiatric settings where people, primarily children, are the ones that report night terrors, screaming and slow wave sleep, no recollection of ritual upon awakening. So they don't qualify as nightmares because those people tend to have the content stick with them. Somnambulism or sleepwalking, REM sleep behavior disorder, and complex behaviors of sleep. I would say that all of these things can also be triggered to some extent by medications. There are a few good case examples of drugs like Ambien causing some of these problems that weren't present before. Is it the dopamine agonist that caused the compulsive behaviors? That was confusing. Going back to this slide, I think, yes, when people get the dopamine agonist, they start to do some of these things that are problematic, and then you stop the drug and it gets better. Sorry about that. Sleep hygiene, these are just the classic things that we probably should and ought to be telling all of our patients. Using the bedroom for sleep and sex only, don't eat there, don't watch television in bed, and be careful because otherwise you just confuse the reticular activating system by doing an activity that should normally be associated with wakefulness. Avoid bed and computer for 2 hours before bed, and of course while you're in bed. And I would now expand the computer to mean the smartphone. I know so many people that tend to set alarms with their phone, but they also grab them, and the light from the phone can be problematic because it sort of tells the pineal gland to wake things up again. It's okay to read for pleasure in bed, but not okay to read to learn in bed. Some people think about having a very boring novel next to the bed. My only concern would be if you're using, say, an e-reader that lights up, or if you have one of those little book lights that goes on top of a book, then it may not be so much the reading, but the light that will cause problems for you. Exercise in the AM or at 4 p.m., again, not too close to the sleep time, and try to synchronize your wake cycle 7 days a week. In other words, don't do it's the weekend, I don't have to get up. I know we're all prone to do it and think we can catch up, but it then does create problems because when Monday morning comes around, there's this very severe grogginess that causes problems. So looks like that's the end of our didactic. We made it through, and I know that there might be some questions lingering out there in the audience, or this has maybe triggered some questions about people that you're working with. If so, this would be the time to chat with us. We still have some time left.
I do have a couple of questions, Dr. Bond. This is Catherine. My father has sleep apnea, and I believe that he needed a change in pressure for quite some time. His sleeping was getting worse. Is one of his doctors, and I think it was, well, I'm not sure which one it was, gave him Nuvidil. And he felt so much better, but it's a stimulant, and it's a new one. I don't know what his plans were for keeping him on it or not, but what can you tell me about that?
Nuvidil as a wakefulness agent?
I see.
Did I hear you correctly, that he was diagnosed with sleep apnea, and you mentioned something about pressures Are you there? Well, we seem to have lost audio from Catherine, but my understanding is that yes, both Provigil and Nuvigil are stimulants. My sense is that they're not as troublesome as some of the other stimulants. For example, giving someone Adderall or say Ritalin for this disturbance, because those aren't necessarily as indicated for it. I haven't myself had a great deal of experience in prescribing those over the long haul, but I think of them as being less associated with the biggest problems like tics and in some people psychosis because they're not quite as dopaminergically strong. That's my impression of them clinically. I would probably have to talk with someone who does more direct treatment of narcolepsy. Typically, for me, someone comes with that diagnosis. They may be on one of those agents, but especially with the Nuvigil, I think it is approved for long-term use by the FDA. But again, if people have underlying anxiety or what I would call something that's likely to be aggravated by stress or by stimulation, then it could be problematic. I guess it seems like it treats the symptom as opposed to the underlying problem. It keeps them awake during the day, but then they still have the trouble with sleeping. So there are those folks that come in a sedating agent for sleep, and then they have a stimulant like Nuvigil or Provigil during the daytime. And I tend to try to avoid the stimulants as a psychiatrist and focus on, well, what is interrupting your sleep, and can we do some behavioral interventions around that? There's a question from Dr. Pierce about long-term efficacy and use of Ambien safety. Well, I'm kind of mixed on this one. I generally advise people that I think of sleep agents that they should be used for about 2 weeks or more. 2 weeks or less. Ideally, by that point, whatever's disrupting your sleep should have improved and should have gotten better. Maybe you can get your sleep hygiene back on track. However, there is a problem with, I guess, the chronic insomniacs who like Ambien, who take it and who don't escalate the dose. As long as they're staying within the prescription parameters, they're not overusing it, they're not running out of it, losing it, then I tend to be okay with it. I personally don't like to go above 15 milligrams. I don't like to go above 10 in someone who has any type of obstructive problem. And there are those folks who do come in with the diagnosis of sleep apnea who have said that it's the only thing that allows them to sleep, but I just warn them about the risks. I think in terms of the side effects, the long-term problems are most focused on memory and coordination difficulties. I advise people not to drive, especially when they're first adjusting to these agents, and to give themselves plenty of time to wake up. But I've had a large number of folks, I would say maybe about a quarter of the prescriptions that I write who remain on some sleep aid, be it Ambien or Lunesta, for an indefinite period of time, who've used those prescriptions, I would say, carefully and judiciously, that I don't get overly concerned about misuse or diversion. But when I get a hint that they're escalating the dose and chronically running out before the prescription is done, then I get more concerned. Another question from Dr. Johnson's group. Have you found that co-sleeping with an infant reduces sleep disturbances in the parent as compared to the conventional method with a child in a crib? Is that a trick question? Well, I don't do a lot of work with new parents that have parent-child-infant issues. I would say I don't know enough about that one to address it. I haven't seen that. I guess my sense would be that whatever the literature says about co-sleeping, assuming that it's not going to be where you put the child at risk, because I've heard of parents that are very tired rolling over and crushing a child. I don't know if that's what you mean by co-sleeping, or if you mean having been in bed with them. I'd have to defer to a child psychiatrist or a pediatrician on that one. Is there something that I'm missing, or something that you want to share with the group that you know?
Hi, I think this was Matt's question, and I think he was looking more at the sleep behaviors for the parent rather than when the child, an infant having a very different sleep cycle and waking multiple times during the day. They sleep 16 hours, but they don't sleep them all at one stretch. This, of course, causes disruption to the adult's sleep architecture. And he was trying to find out, is it a little bit better if you can be there in the bed with the infant and therefore reduce the disruption to your own adult sleep problems, because you don't have to wake yourself up fully to get out of the bed, go down the hall to the baby's room and take the baby out to feed it, etc. There are issues with co-sleeping, as you mentioned. It's usually if either parent drinks or if either parent smokes. Those are indications that you should not co-sleep. But if parents are otherwise healthy, then I don't think that there is significant additional risk to the infant for co-sleeping. But I could see it being more disruptive rather than less, because if parents can arrange their social life within the family, that each parent can take a turn, so to speak, at meeting the infant's needs at night, then it allows the other one or the other parent to rest for a night rather than being disrupted. Because that would put them onto that scale of making 8 different mistakes in attention throughout the day, which could be problematic. So, but I think it's going to, the real answer is it depends. It depends on the family and on the kid. You know, how well is the infant sleeping? So it's a tough one.
I can't say that I can shed a lot of light on it. It's not a problem that I've run into personally before, but I think my own education, which is a bit dated now about co-sleeping, was that it was kind of a no-no, but it sounds like maybe the beliefs about that are shifting as we learn more about particular contraindications, so appreciate that input. Any other questions? Well, maybe what I'll do is talk a little bit about, Karen points out that her son was a sleepwalker as a child, but as an adult doesn't have that problem. Can you speak more about this? Somnambulism, I think, is more common in kids. I think whenever there are complex sleep behaviors going on, it's generally a disturbance in that part of the brain that's supposed to cause us to be paralyzed when we're in stage 4 sleep and also in REM sleep. But when you get disruptions, whenever someone's doing that as an adult, it's considered a sleep disorder. But I don't know. I mean, I think that some people just grow out of it, but there are those folks that have taken Ambien who will have this problem, but it's generally because of a more primary disturbance in sleep, whereas in kids, I think that the mechanisms that control sleep and wakefulness just aren't quite as fully fleshed out yet, and so they can sometimes do these things. I think that's also one of the reasons why bedwetting can happen in kids, but doesn't tend to happen as people grow older, because the neural mechanisms that are responsible for manifesting control over when one is asleep and awake tend to get more, I guess, experienced. And you don't tend to have those types of errors in the mechanics of sleep. I wanted to speak a little bit about interventions in terms of the medications and what someone might land on. So I'll talk a little bit about some of these cases. Karen asked me if I could think of a few. These aren't fully fleshed out, but they are based kind of on real people that have been modified for this format, so to speak. There's a patient who I'll refer to as John, who came to me with a complaint of what seemed to be a bipolar disorder, some type of variant mixed in with a little bit of OCD. Just a very worrisome, perseverative person who in childhood had been treated for OCD successfully, but came to me with kind of over-worry, honestly, about a romantic relationship that had ended and found himself perseverating over this past girlfriend, was really unable to kind of move on, felt slighted by her in a number of ways. And one of his classic things would be that he'd sit awake at night thinking about, worrying about this person and the relationship and how he'd been mistreated. A lot of revenge themes would come up. And despite the fact that we got his mood and anxiety level better by a combination of an SSRI and Lyrica, honestly, for the mood, this sort of insomnia persisted really, and it seemed to have a bit of a seasonal component. So at one point we did try with a light box, which provided some relief, but then the insomnia seemed to persist, and I really wondered if it was because of the SSRI. So we tried weaning off of that, but honestly, it was the only agent that seemed to really work to control both the anxiety and the OCD components, because the worry seemed to get worse. So being on a mood stabilizer alone didn't seem to be the right answer. So we ultimately went through a series where we tried first Benadryl, and that worked for a while, but then kind of wore out. It's always a first go-to for me. Then we went on to melatonin. We went up to about, I think, 5 milligrams, which he bought through Amazon, and that provided fairly good relief. And then he did a period of time with melatonin. and Benadryl together, but I got concerned about oversedation. This is a person who was kind of afraid to try Ambien because of some of the literature reports. And I think there might have been a cost issue as well because these things were generic, but the Ambien wasn't something that was covered. I don't think this person had the greatest insurance. So ultimately what we landed on was a low dose of Klonopin 0.5, which we did because he had some daytime anxiety, the belief being that the Klonopin will help with the middle insomnia that he had, and it might also bleed into the daytime, where mornings were the worst time for him. Getting up, get going, it seems like that was when some of the separation would happen. So by doing low-dose Klonopin at 0.5 now for, I think, over 6 months, this person's really been able to have a pretty good response. But it's just one of those things where you kind of march up the ladder, and ultimately you land on something that is more difficult maybe to prescribe because you think about a controlled substance like Klonopin or Ambien as being less desirable, but certainly it was an affordable option for him because it's an old drug and it's been around for a while. Do any of you encounter current sleep things? I'm just wondering, what do people tend to go to as a first-line agent for sleep? Trazodone, certainly a great option from Dr. Pierce. And in men, of course, you want to put in a chart warning about priapism, even though it's rare, about 1 in 10,000, I think, or somewhere around in there, 1 in 1,000 to 10,000. It's something that if it happens to your client, you want to make sure they've been informed about it so they can take proper measures to get decompression. It's a trip to the emergency room, basically, if it doesn't go away within 4 hours. And to my knowledge, it's not dose dependent. It's something that can happen idiosyncratically. But there does tend to be some leading up warning about it. It tends to be more persistent morning erections that tend to become more prominent and then lead up to priapism. And in Jessica Roberts, I recommend melatonin first. If they haven't tried it, then go to RX drugs. Prescription medications, great. I think melatonin is something that I used to have a little bit more fear about, but then when I learned that many folks in primary care start with it without concerns about the hypothalamic pituitary axis, seems to be kind of a low bar. There is a prescription agent, Rosarum, that's similar, that hits the melatonin 2 receptors that some people will benefit from it. Melatonin by itself isn't quite strong enough.
Interestingly enough, you know, when women get older and are postmenopausal, oftentimes they have a problem with sleep. So it was recommended that I take melatonin, and I was on it for, I want to say 2 or 3 years. And just decided that, you know, after speaking with you on our sessions, that maybe I didn't want to stay on this. So I tried magnesium, which I didn't have a lot of in my diet per se or in my vitamins, and tried a little bit of magnesium, and don't you know that it works just as well as the melatonin? Which was a surprise to me.
I had not heard that, but there might be some science behind it. Well, in the absence of other questions, I'm just going to talk very briefly about another person who I saw, who I suspect is a slow metabolizer in the sense of the P450 system. This is a gentleman who also has generalized anxiety disorder. And when I first started seeing him, probably about 10 years ago, hypochondriasis was really, really a big part of the picture. Just over worry about a lot of physical symptoms with the persistent fear of having something bad like stomach cancer or a brain tumor. Just those things tend to bubble up to the surface quite a lot. But even when his anxiety got better through psychotherapy, there was a problem with sleep. So we decided, since he had an underlying anxiety problem, that we would use gabapentin or Neurontin as a but as a aid in anxiety. And lo and behold, when he took 300 milligrams, he slept like 12 hours and couldn't get up. So we dialed back to 100 milligrams and still had the same problem. So ultimately we got a liquid version of the drug, and he took like a few drops. And it was actually something that helped him to sleep because he was so exquisitely sensitive to it. So at this point now he has 100 milligram tablets. He's slowly developed tolerance to it, but it only works for a period of time. So it'll work for a while and then it will stop working. So what we've done is we now do the shifting around where he goes from gabapentin for a few nights, 100 milligrams, and then he'll take Benadryl just an over-the-counter dose for a couple of weeks. And by that point, he can go back to the gabapentin. So he kind of switches back and forth and is able to maintain pretty good sleep. And during the periods that those things don't work, then we go to one of the bigger guns like either Ambien, and in some cases he's taken Valium. And I have a few other people who are like this, where they have, or they like to have in their arsenal more than one sleep agent. Sonata is a drug that's fairly short acting, and people can take it when they need to get up early the next morning to be functional, like to go to a meeting or to go to work. But meanwhile, when they have a weekend ahead of them and they can sleep for a longer period of time, they might take Lunesta or Ambien. They like to have maybe a variety of different things, both short-acting and long-acting, in the sense of deciding how much time I have to sleep when I come in and how late it is when I need to take something. Because if you need to take something in the middle of the night because you keep waking up and waking up and waking up, if this isn't a regular experience, it could be that Ambien with a 6-hour half-life is going to keep you asleep the next day. But if you can go with something like Sonata or Temazepam, Restoril, then you can maybe get the 2 to 3 hours that it helps with and be fine the next day. So sometimes it's about tailoring the sleep agents to the sleep problem. I'm guessing that the person who created our presentation may have been from a sleep background because they didn't talk about drugs at all. But we know that in the primary care and also psychiatric settings, sometimes they become the mainstay. So there is a question, we dial back a little bit. Is there a reduced efficacy of Ambien when paired with narcotic drugs for pain? I would say no. In fact, quite the opposite. What I've seen is that some of these drugs can be synergistic, and a lot of people will find that the narcotic might get them partly to sleep, the Ambien might get them partly to sleep, but honestly, if they take them in combination, then they're able to sleep through the full night, which is always very scary because you're thinking there are multiple controlled substances, and with the overuse of prescription agents at this point, one doesn't want to just be loading people up. But I would say that chronically, I don't see them being less efficacious, but they do tend to work synergistically together, but I don't know that one works less well with the other on board. Wow, this has been a little bit like oral boards today with the unknown grab bag approach. Thank you all for your patience, and certainly if there are other questions that come up, maybe we can talk more about them next time. If you think of a case, do please submit it, and I'm going to hand the ball back over to Karen.
Okay. Really, I have nothing more to say. Hopefully you'll get some cases in. Of course, this is one of the few times I think we may have had 3 sessions where we didn't get pre-submitted cases. And this is one of them. But the next, I'm just looking at the calendar, so our next adult psych is on June the 11th. And we will see you then. And thank you so much for coming and for participating today. And thank you those from Oregon who came on. And you're perfectly welcome to give me a call if you want to do any debriefing. And I'm just copying and pasting our survey into the chat box here. There you go. Thanks, Dr. Bonds, for reminding me. So please fill out the survey. Either click on the link here or copy and paste it, or I will send it later this afternoon as well. So you have plenty of chance to do our survey. Thanks so much. See you next time.